Okay, I think we can get started. Welcome, everyone. Glad to see so many familiar names, if not so many faces here today. I'm happy to introduce Dr. Julie Dombrowski and Lydia Chwastiak. And they're going to be talking about their work to integrate mental health into HIV services. If you will just give me 1 second, I'm moving things around on my computer screen. A brief introduction. Dr. Julie Dombrowski is an associate professor of medicine at the University of Washington and deputy director of the Public Health Seattle and King County HIV, STD, and hepatitis C program. And Dr. Chwastiak is a professor at the UW Department of Psychology and Behavioral Sciences and adjunct professor in the Department of Global Health. She's also the director of the Integrated Research Core of the UW Behavioral Research Center for HIV, or UW Birch. And we're very happy to have both of you here today. So Julie, I'll turn it over to you.
Okay, sounds great. Thank you so much, Roxanne. And thank you all for hosting Lydia and I for this Lunchbox talk today. We are really excited to present to you and to get some input. The title of our talk is Integrating Mental Health and HIV Services, Local Research in Both Directions. And what the title is meant to imply is that we are working, Lydia and I, on some projects we'll present to you today. First, my part, which is around integrating behavioral health services into low barrier HIV care. And then in the second session, Lydia will talk about her work integrating HIV prevention and care services into behavioral health services. This is really a work in progress session, so I'm certainly going to present some data to you, but we would really love your input and have tried to design this to leave plenty of time for that. So please think about your questions and suggestions as we go along. All right, so I'm going to begin by talking about integrating behavioral health services into low barrier HIV care. I want to start with the context, which many of you know very well, but this work is really focused in King County, Washington. And the latest estimates of our care continuum are shown here. This is from the surveillance report released last month and covers the calendar year of 2021. And what you can see is of the people diagnosed with HIV, 87% are virally suppressed. So really a lot of our work in ending the HIV epidemic in general, and in this research in particular, is focused on reaching that 13% that are not virally suppressed. And when you look at the absolute numbers circled in the purple circles down there below, at any one time, we estimate there are around 600 to 900 people with HIV who are virally unsuppressed. Some of those people become suppressed again pretty quickly, others have more extensive need. But I say this to emphasize it's a relatively small population we're talking about. This is really an important and elite group of people who we're trying to change our services for and reach effectively. And we are not talking about thousands or tens of thousands of people like in other jurisdictions or projects. Low barrier care is care for people with HIV designed to engage people with complex medical and social needs who are not engaged in conventionally organized medical care. So what you can see here is a network of 5 low barrier clinics in King County that have really evolved as part of a strategy of differentiated care in King County. We have our conventionally organized medical care, which is really an extremely high standard, superb comprehensive care with wraparound services. And then for people who still aren't engaged in services, even with case management and outreach support, the low barrier clinics are really designed to engage that group. The MAX clinic is located at Harborview, so in central Seattle, and that's where a lot of the work I will be talking about today is focused. The MOD clinic is also at Harborview, but a walk-in clinic for people with HIV who co-located with Madison. The She and Aurora Clinic are in North Seattle. That's a status neutral clinic, people with or without HIV. That's a partnership between Aurora Commons and Harborview. And then 2 new clinics in South King County, one opened recently, the other will be soon, that are partnerships between Harborview and Catholic Community Services, the Engage Health clinics. So although I'm talking about the MAX clinic, I think the challenges and the successes we're going to describe are applicable in low barrier care more broadly, and certainly even outside of Seattle in other areas where this care model is evolving. So what is the problem we're trying to address? Well, I'd like to start by showing you some work led by Eden Altwies, who's a fourth-year medical student, and did a summer project really digging into the Max Clinic data to understand our comorbidities and the success of our linkage to services. And what you can see here is that among Max Clinic patients enrolled in the first 5 years, really extraordinarily high levels of homelessness or unstable housing, substance use, primarily methamphetamine, and psychiatric diagnoses, some of which are depression, but also some more complex mental health disorders like PTSD or psychosis. And really, it's the overlay of these three that you see in the Venn diagram that makes people's lives much more challenging. 42% of people in Max Clinic have all three of these factors, and almost everybody is dealing with at least one. And when we look at our referrals, less than half of patients from the Max Clinic who we referred to psychiatry or to OUD treatment made even one visit. So that's a group of people who are willing to have a referral and agree to a referral. And we're referring patients to services on the same medical campus, right? Max Clinic is in 9th and Jefferson building. Madison's Clinic psychiatry team is right across the way. Harborview Mental Health and Addiction Services, less than a block away, and office-based opioid treatment also in Harborview Medical Center. And still, we just haven't seen success from referring people outside of Max Clinic. So from that work, we concluded that we needed a model of integrated care and looked for an evidence-based model to do this. And this is a model that Lydia has a lot of expertise on, that was developed at the UW and has been studied a lot here as well as elsewhere. Collaborative care is an integrated care model in which embedded behavioral care managers, as shown on the lower left of that triangle, work with primary care providers and are supported by a psychiatric consultant. The care managers meet frequently with patients to provide brief behavioral treatment, help manage medication when appropriate, and coordinate care. And the core elements of this intervention are shown in the box below. It's really a person-centered care team, population-based, ideally looking at all of the patients in a clinic, all enrolled in the program, and proactively tracking those patients. Provides evidence-based care, both psychosocial and pharmacologic. And measurement-based care is a key part, really systematically using validated measurements to identify patients who aren't reaching treatment targets and adjust their treatment accordingly. This model has been studied extensively for depression, over 80 RCTs, and in one of the largest was shown to reduce depression or meet essentially successful targets for depression treatment, increase that by about 50%. It's also been studied for opioid use disorder in the form of the nurse-managed model, which is like the OBOT clinic at Harborview and also the Massachusetts care model some of you may be familiar with. Judith Suey, who's one of our co-investigators on this work, has led a lot of the work in that area. Okay, so we got an R34 to study this, and really our overall goal was to develop a replicable strategy of implementing collaborative care management for the treatment of depression and OUD in a Ryan White funded low barrier HIV clinic, the Max Clinic. And we focused here on depression and OUD because that's where the evidence is for this intervention. Our aims were to develop a model to integrate into the clinic and to evaluate the feasibility, acceptability, appropriateness, and some of the behavioral health outcomes over the first 6 months. This was an implementation science grant, and we used the EPIS framework, which really focuses on the phases of implementing an intervention, and a multifaceted implementation strategy developed by the Ames Center here at University of Washington, which does a lot of work to integrate mental health care into primary health care. I'm not going to talk a lot more about that strategy, but would welcome discussion during today's talk. So one of the first steps was doing pre-implementation interviews. So if we're going to put collaborative care into the Max Clinic, we needed to hear from the service delivery stakeholders, which were the staff as well as other people involved in the Max Clinic, and from patients. And a lot of this work has been led by Scott Halliday, who's a PhD student in implementation science. And we heard some really interesting themes in these pre-implementation interviews, which I'm just briefly summarizing here. So of the service delivery stakeholders, mostly staff, there was definitely a feeling that in-house behavioral health services would be better than the current standard of care. Again, staff had really seen that drop off and lack of linking people to specialty services elsewhere. And there was measured receptivity to the idea, in part because of the extent of patient needs and needing to respond to acute needs. So recognizing patients had a variety of psychosocial needs, and they may or may not prioritize mental health care in the context of their many other needs. Among patients, almost all had prior experience with behavioral health care. So it was rare that somebody hadn't engaged in behavioral health care of some form, and often described their past experiences. One thing that I thought was interesting, this came up in several of the quotes, was that among people who use drugs, they often felt like they had sought mental health care and not received what they wanted because people were focused primarily on stopping the drug use or addressing the drug use rather than the mental health, which was the priority for the patient. And there was this, they echoed the staff sense that receiving services in a familiar environment within the Max Clinic would be preferable to referral elsewhere. So then we did some work to adapt this model for the Max Clinic context. And there was a research team that included Lydia, Scott, who you saw, myself, Kenny Scher, and Deepa Rao, and Judith Sui. And we worked with a small group among the Max Clinic team, as well as talking to the overall team to figure out how we could make this work. And in the end, this table shows how we were able to maintain the structural elements of collaborative care. So that addition of a care manager, a consulting psychiatrist, the population-based registry, evidence-based interventions, and having a care plan. And really what we needed to change were the process elements to adapt this for the walk-in clinic, and recognizing that patients were often coming in for incentives and acute needs and may or may not be prepared for the idea of sitting down for a mental health intake or session. We did adapt the proactive and systematic patient identification. So in primary care, this usually depends on things like depression screening, typically with the PHQ or Patient Health Questionnaire 2 screen, followed by the longer PHQ-9. This is common in primary care. Many of us have probably completed it as patients. In the Max Clinic, there was definitely the sense among the staff of, we already know these patients. Many of them have been diagnosed with depression and have just had trouble accessing care, and that it doesn't make sense to necessarily do a PHQ with every patient walking through the door or a NIDA drug screen, and that didn't fit very well with the Max Clinic model. So we did adapt that to have social workers and eventually other members on the team address essentially screen patients for the appropriateness for collaborative care, especially among those who had already been diagnosed with depression or OUD. We didn't incorporate systematic quality improvement in the beginning, in large part because this was a pilot, we were getting it up and going. We certainly had a lot of conversations and tried to change things as we go, but didn't have formal PDSA cycles like one would in a more stable program. And then really interestingly was this issue around measurement-based care to track patient response and adjust treatment targets. This is core to collaborative care. And we experienced a lot of challenges with the PHQ-9, both at the point of screening and trying to identify patients for collaborative care, and in the context of the behavioral health care managers work with patients and using that measurement repeatedly over time. This was adapted, but I would not say this was not a proactive a priori decision. It really was adapted largely by staff doing the program as they went along in response to what they perceived as things being acceptable to the patients or feasible. I'll tell you more about that in a bit. So this shows the outcomes from the first 6 months of the intervention, which was in 2021. And what you can see among 222 active Max patients at that time, 186 had a visit, pre-screened 152. So again, those are people who we knew had already been diagnosed with depression or were using opioids. 69 were screened by the care managers or the other members on the Max team for their appropriateness for collaborative care. 55 referred and 27 who had an intake. And so What was interesting here, certainly there's a big drop off, and I'll show you what we learned in the post-implementation interviews. When we look at that number just from referred to intake, my understanding, and Lydia, you can correct me later, is that that drop off is not so atypical. You certainly see in primary care that not everybody referred to collaborative care management does do an intake with the behavioral care manager. But certainly when we look back through this cascade, we can see there were a lot of patients in the Max Clinic who weren't engaging in this model. And then we did some post-implementation interviews. Scott, again, led these with also some work from Caitlin Zinsley. And I'm showing you some themes and quotes here. There's really a lot more, but just want to highlight some of the key issues along with this cascade. So when we look at that drop off, even to people who were screened for appropriateness for collaborative care, a lot of themes came up around time, priorities, and clarity among staff about what the behavioral care manager was doing. Despite our best attempts, there was still just some confusion about what was the behavioral health nurse managing or offering. And the staff very commonly perceived that they just didn't have the time to fit this in with other things, especially when patients were presenting with acute needs or for incentives. And again, staff reflected that perceived low priority for patients, as you can see here, patients coming in for incentives, wanting to get back out the door, that it was a little hard to insert the idea of a depression or substance use screen in one of those encounters. And then we heard a lot as well about the challenges of using the PHQ-9 and the NIDA standardized screening. For any of you who are not familiar with the PHQ-9, it's a set of 9 questions that is designed to, and usually can be done pretty quickly in primary care, that essentially asks, how often have you experienced these things over the past 2 weeks? And we heard a lot in the post-implementation interviews of things that reflected what we were hearing from the team as we went along about their challenges of using the PHQ-9, even for that initial step. So for instance, they often already had great relationships with the patients. It felt awkward and strange to switch to a standardized questionnaire, and they didn't really feel like they could work that into the encounters. One person described some of the wording on that instrument as feeling like it was turning the knife or something, like the question that asks about how often you feel like you're a failure to yourself and family, especially people who were totally estranged from their families. And then the experience that it took a long time, and I experienced this myself, that with patients who the team knew well, they would ask a question, the patient would bring up a big key issue or would want to go into it, would want to have more discussion, and it just wasn't done in the way that we typically can envision a screening instrument being used. I do think there were also some themes among variable buy-in among the staff. Many staff were really excited about this. Others, I think, had some misgivings or concerns that were reflected in that first standpoint of getting people referred to collaborative care. Okay, there were some really important success stories. So I do want to also highlight those, that of the people that got to the point of talking with the behavioral health care nurse, really they spoke very highly of their experience, that it was a different kind of behavioral health encounter than they had had before, that it had really helped them. Staff identified some patients who had really benefited from that, and in general felt that the behavioral health care nurse integrated well with the team and was very good at what she did. So some conclusions, I think in some ways we're still working on these conclusions, but I would say to the point of the specific aims, collaborative care was acceptable and feasible with adaptations to improve the fit for low barrier care. I think it was moderately appropriate considering the patient complex social and behavioral health needs, and it had somewhat limited reach. So there was some important success, but we needed to do things in phase 2 a little bit differently and think again about how to reach patients. So we are doing a phase 2. There's a licensed mental health counselor instead of a nurse who's really focusing on the mental health piece without the OUD piece. I'm not getting into all the details here, but I'm happy to discuss that. And really is working with the clinical team, doesn't have the same kind of PHQ-9 screening step. And has already certainly reached a lot more patients, but we are still in the process of evaluating and measuring that. But also, can we reach people who aren't coming into clinic? Trying to get people at the time they come into clinic when they have a priority, this maybe isn't the best time to do it. And then there are a group of people who aren't coming into clinic at all. So one thing we are working on now is developing a mobile team focused on HIV care and mental health engagement. Can we improve HIV physician ability to address psychiatric problems? So since the physicians are seeing the patients, can we help all of the HIV providers be more comfortable with addressing some of the mental health issues that come up? And to that point, we have a low barrier mental health case conference ongoing that Lydia really leads with the physicians involved in low barrier care. And then can we deliver mental health care in a way that's more acceptable? I think that's what we're just still trying and talking about. And then the question of incentives in the context of the Max Clinic in particular always comes up. And some people have raised, should we incentivize participation in behavioral health care? Importantly, as this work has evolved, we have gotten support from EHE funding. The local advisory council here really identified mental health as a key priority, and EHE is funding some of this behavioral health care program in Max and the mobile team. So one slide, just want to tell you this is in development. The idea of the mobile team is influenced by models like street medicine and PACT, or the Program of Assertive Community Treatment for people with mental health. That's a much more comprehensive model than what we'll be able to do, but is a multidisciplinary team working to provide services in the community for the client. We have a planning team from multiple agencies involved in this, and Peer Washington recently received funding for the peer part of this program. And we're talking with a lot of our local experts who've done similar work to this before. So that remains in progress. Would welcome thoughts, advice, and lessons from any of you with expertise in this area. So with this acknowledgement slide, I want to just mention certainly Lydia, who you'll be hearing more from next, the research team, the behavioral health care teams, the low barrier care teams who've really all been essential to this, and funding from NIH, as well as King County EHE program funding shown there. So with that, thank you very much. I will go ahead and turn it over to you, Lydia, for your part of the talk.
Great, thanks so much, Julie. It's great to see this work presented. I'm really delighted to be here. So we're going to shift gears to really focus on prevention, and also to focus on more of the work in progress part of the talk. So similar to the mobile crisis team development supplement, this project that I'm going to be talking about for the next couple of minutes is also funded as a supplement to Birch, and it really focuses on bringing services into behavioral health organizations, and really bringing behavioral health organizations kind of to more systematically and formally to the table of ending the HIV epidemics in King County. So wanted to just kind of talk a little bit about where this idea came from, that in recognition, kind of if we move away from the low barrier clinics, actually the next slide, Julie, is the rationale for the project. We think about among people who are at high risk for HIV, or certainly among new infections in King County, there are very high prevalence rates of serious mental illness and complex behavioral health needs. And so the rationale for this project of working with behavioral health organizations is the recognition that to achieve the 2030 targets, we really have to have a better strategy for reaching individuals with complex behavioral health needs. And so thinking now, kind of, again, moving away from the low barrier clinics to thinking about the prevention pillar of the plan, one of the really sort of interesting and innovative components of the prevention pillar supports organizational change at the healthcare system level to increase access, improve quality of care. So the rationale for this 1 year Birch supplement is really to think about HIV prevention, to recognize that it is very aligned with the care that's provided in community mental health settings, right? This care is recovery oriented, it's very person-centered, it's holistic. We think about, providing care to the whole person. So community mental health settings are specifically designed to meet the complex behavioral, to meet complex behavioral health needs. but to this point, they have not really formally or systematically been part of the healthcare system efforts of the plan to date. So I wanted to recognize that we have a really terrific team working on this supplement. So from Birch, in addition to Julie and me, we have Pamela Collins from psychiatry. David Katz is working on this. We have a great grad student from psychology, Mira Reichman. And we're partnering with Becca Hutchison and the team from King County's Ending the HIV Epidemic, and Lori Silla and our colleagues at the AETC, and have an implementing partner working with the King County Behavioral Health Provider Association. So just kind of an overview, as I said, this is a one-year supplement, so really hoping to gain some input. We started on this in October, so wanted to kind of provide some of our initial work and get some feedback on some specific questions. And as I said, this is really in recognition of the need to reach people with complex behavioral health needs with HIV prevention services, but thinking not only of the population, but really focusing on the setting, the need to expand, in particular, HIV rapid testing and linkage to services within existing care delivery settings, and in this case, behavioral health organizations, and really kind of focusing on organizational change. This is also an implementation project, and we're moving towards writing an implementation grant. So really not thinking so much at behavior change at the provider level or the patient level, but really thinking on organizational change at the level of the healthcare system. So the whole idea for this project came out of conversations that Julie and I had with Becca Hutchison, who was reminding us of the learning collaboratives that are already part of the prevention pillar for the EHE plan. And this is, a really exciting and innovative approach to expanding access to prevention services. And it's based on an evidence-based implementation strategy, the IHI Breakthrough Series model. So I don't know if, I think a lot of people might be familiar with this model, but essentially, the idea of a learning collaborative is to support practice change, to either implement a new program, implement an evidence-based practice, or support practice change through a learning system. And in this learning system involves either leadership or teams from a group of healthcare organizations. Typically, sort of 5 to 10 organizations will participate in a short-term kind of learning system. So the IHI typical length is kind of 12 to 18 months. And so these teams or leaders come together for regular group meetings, and they're basically getting feedback from experts, engaging in peer-to-peer learning, which is a big part of the structure of these learning collaboratives, but they're very data-driven. So the idea is that organizations will select common goals and metrics, work on sort of a shared vision of what improved capacity, what increased access would look like, and then through this iterative process, bring data, share data. They're developing an organizational specific improvement team and project, and they'll refine this over time. So these learning collaboratives have launched with good success for emergency departments, pharmacies, primary care organizations. You guys may be familiar with some of the existing collaboratives. So the background for this was we were thinking about, what would a learning collaborative for increasing HIV prevention services in behavioral health organizations look like? And so we saw the opportunity to submit a Birch supplement as a really important opportunity to do some formative work. Because honestly, in trying to develop a learning collaborative for behavioral health organizations, we were missing a lot of important information to try to tailor the emergency department learning collaborative for behavioral health organizations. So the specific aims are on the next slide. Really, it's a very formative project over the year for us to first utilize a mixed methods approach to really characterize the current HIV prevention related services and practices and the barriers and facilitators to providing the services among 65 King County behavioral health organizations. And so I'll talk about that in a minute, what those parts of the mixed methods approach look like. And then our second aim is to do a deeper dive with 3 partner organizations to understand the important barriers to delivering HIV testing and PrEP referral or provision, and tailoring an implementation strategy so that we can test that in a subsequent grant and use that to build capacity for providing HIV prevention services in this context. So a word about the setting. One of our big challenges, I think, as we're getting started with this work is that the behavioral health organizations, and defining that as any healthcare organization that's providing, or any organization that's providing publicly funded mental health services to low-income people in need in King County. They're contracting to provide Medicaid behavioral health services. And this is not a monolithic group. These organizations range from inpatient and residential substance use providers, providing only substance use services, through kind of more general outpatient mental health clinics, and sort of, through to social service agencies that really focus on addressing social services, but provide some behavioral health services in that context. And these are largely housing organizations, big housing organizations, focusing on homeless services for individuals who are living homeless. So when we look at the organizations themselves, sort of as we think about what's the landscape analysis, how can we characterize HIV prevention services, in this, among these organizations, we've got a lot of heterogeneity across, with respect to the focus of organizations, their size, their staffing, who they're serving, what behavioral health services they're providing, and then interestingly, whether or not they have integrated primary care available. So it's just sort of the infrastructure for providing any kind of medical care or preventative care. So a really an interesting but challenging part of the project is just the nature and the heterogeneity of these organizations. So as we think about aim 1, as I said, is a mixed methods approach to characterizing practices, workflows, barriers, and facilitators of current services. So the 2 parts of that, the more quantitative part is what we're calling an inventory of current practices. And this is an online survey that we're asking, that we're going to send out. We're actually hoping to send it out in the next week or 2. We've done a lot of work to sort of revise the inventory. But we're basically going to send that out to each of the organizations to have a single individual administrator complete, and focusing on HIV testing and specifically linkage to PrEP services, but also capturing some other aspects of the organization. And then based on the inventory, we'll identify 3 partner organizations that will do a deeper dive into exploring barriers and facilitators to the implementation of HIV testing and PrEP through semi-structured interviews of leadership, clinical staff, non-clinical staff, and clients. And we'll do this through a rapid qualitative approach that is informed by the CFAR implementation framework. So to say a few words about the survey, as I mentioned, we really want to understand the nature of these organizations, their infrastructure. So the survey, it's about a 30-minute survey at this point. We're sending it out through our contact at the Provider Association to identify a single individual to respond for the entire organization. So we're hoping that this will be someone who's an administrator who has some deep knowledge of the clinical care that's being provided. So offering an incentive, a $50 gift card to complete this sort of 30 to 40-minute survey planning to do a phone follow-up to follow up on questions if there are organizations that are providing some services, have infrastructure that they could either provide more services, build capacity. So the survey itself will have questions related to the organizational characteristics that I described a moment ago, size, staffing, population served, special programs for high-risk populations, the nature of the behavioral health services they provide, any general health services that they're providing, and then a lot of questions that the sort of substance of the survey relates to what they're currently doing with respect to HIV testing, referrals to PrEP, or actually prescribing PrEP. And then we have a section at the end, which has been sort of interesting to kind of think through and work on, really trying to capture the importance of this topic, given what the kind of nature of working in community mental health right now, with a lot of staff turnover, workforce shortage, burnout, just really understanding how important is this topic. What are the attitudes about providing these kind of services within, is this consistent with the mission of their organization? What is the attitude around their staff providing these services? And then their interest and bandwidth in building capacity. If we were to be able to offer a learning collaborative, what do they have the infrastructure to do the data reporting? Would they have the team? Do they have any kind of QI team or approach that they could participate in something like a learning collaborative that's like the IHI Breakthrough Series model? So those are kind of the sections of the survey, the kinds of questions that we're going to be asking, and hoping to send this out, as I said, probably in the next, by the end of the month. And then what we'll do after we receive the responses to the survey, really looking for 3 organizations that we can partner with for the qualitative exploration of barriers and facilitators, and have spent a lot of time sort of thinking through both our framework and the criteria for the organizations that we would sample. We obtain the sample for people to be interviewed. And so landed on the CFAR framework, primarily because of the interest in organizational barriers, seeing this as recognizing the importance of provider and client behavior change being important in building capacity. But if there are organizational barriers that really interfere with organizations providing this at all, such as staffing, lab infrastructure, prescriber staffing, ability to bill for services, workflow issues, that this was really going to be kind of a non-starter. So selecting CFAR, really focusing on inner and outer setting domains and constructs. And then thinking through, we'd want to capture from the 65 who are sent the survey, sort of anticipating that we'd have at least 30 responding to the survey, that we would want to identify those organizations that report that the HIV prevention services are highly important, very important, or extremely important to their organization, to the clients they serve, and that they're already providing some HIV prevention services so that they could be able to speak to barriers and facilitators. And then among that subgroup of survey respondents, we would probably sample based on organizational characteristics. What's the focus of their services that they provide? What is their size? What is their geographic location? What kind of staffing do they have? What type of organization is it? And then, as I said, kind of using a rapid qualitative approach to conduct 6 to 10 interviews at each site from among leadership, clinical providers, clinical staff, non-clinical staff, and then also trying to explore the client perspective. And this is one of the things we were really hoping to get some input on today, recognizing the importance of having client input at an early stage of capacity building, not wanting to create services or encourage capacity building if this is something that clients would not want to access at their behavioral health organization, but recognizing that CFAR is not a great model to capture client level data. And so thinking about, we've been encouraged by some of our implementation science consultants to think about the client data differently, to the client feedback differently, to think about a different theoretical framework and a different sampling strategy. So wanted to kind of talk through any sort of recommendations about whether we should just do a client survey rather than do interviews from a selection of clients at the 3 organizations that we're partnering with. So that's one of our big questions for today. So maybe we can talk a little bit about that at the end. But then, kind of aim 2 is for us to work with, is to really focus on, once we have information about the services that are provided, barriers and facilitators, really identifying an implementation strategy that is very specific to the most important barriers to building capacity. So our plan is to, with these 3 partners that we've done the interviews with, to collaborate with them to either adapt the emergency department learning collaborative, or even explore a different kind of peer learning network so that they can work together as a group to build capacity for HIV prevention services. So this would involve, just concretely a site visit. We would go back to our partners with their inventory results and their interview data, summarize those, and talk about both their own organization's kind of journey to providing these services, expanding these services, and then getting specific input about learning collaborative or other implementation strategy. What is it that you have time and interest and a team and bandwidth to participate in working with other organizations in a peer learning network to build capacity? So I'll stop my section with just some questions that are kind of our current challenges with this project. I think we're very open to any feedback to strategies for increasing the response to the survey. I think one of our big challenges is the heterogeneity across types of organization. And then, as I mentioned, the approach to inclusion of client feedback, whether that's interviews or surveys. I think we're also just very interested in this group's experience in working with behavioral health organizations. We don't want to miss work that's already going on or leads about behavioral health organizations that are very engaged in this already. So, wanting to hear that feedback as well. And then also thinking about our original, for aim 2, our original proposal was to adapt the emergency department learning collaborative, but thinking, is that too rigid? And should we be open to exploring other kind of a more organic approach to exploring what kind of implementation strategy is a better fit for what these organizations are willing to do? So I will stop there, and I think we'll open it up for questions about both projects, all the projects.